working closely with AETC, NC, HCMC to work on the performance improvement section of this meeting.
That's an alphabet soup.
I know, huh? How did I do, guys?
You did well.
I was practicing.
And
we
look at each other and laugh.
Yeah.
And HRSA actually had a longer title for this project. We actually were able to shave off a couple of words. So, I mean,
make it a cute-sounding word anyway. We can put it together in something.
And Kim, I know you let us know who's on your end, but since we don't have the benefit of video, do you mind just having each of your staff introduce themselves so we can at least get to know their voices?
Certainly. I'll go ahead and start because you have some new people on the phone. My name is Kim Taplinger. I'm the Grants and Special Projects Director, and I'm also the QI Coordinator.
Good morning. This is Jolene Joseph, Director of Operations, and I work very closely with the provider and support team. My background is actually, I'm a licensed independent social worker and was instrumental in starting our integrated model of care within our organization.
Okay.
And I'm Janice Thunderhouse. I'm the CEO. We've been with our management team has been with the organization since we formed, or soon after, in 2003. My background is nursing. I have a master's of science in nursing. So we tend to look at our organization very strongly from the clinical perspective because the majority of our administrative team have a clinical background.
Okay.
Hi, my name is Jenny Clark, and I'm actually the Director of Pharmacy Services here at Health Partners, but I also serve a strong role with the electronic health record software program, do a lot of work with that. So I've been here with the organization for about 5 years.
Okay. And is that everybody?
Yes.
Okay, great. So then I just want to briefly go over the agenda and the purpose of today's call. Based on your responses in the assessment tool, we want to be able to validate your responses. So we're going to ask you questions to gain a better understanding of your health center's current capacity as it relates to the project. And we want that information that we get today to really help inform the work plans that we begin to develop with you and be able to identify common themes between clinical and performance improvement. And are you guys hearing any feedback on your end?
Yeah.
I have all of the lines open right now, but when I switch, I'm gonna mute different lines so that we can reduce some of the feedback. All right, so then. Okay, right now everybody is muted, just so you know, just to kind of reduce the feedback. So in terms of what we want to cover today, this morning, we've started with the introductions, and then what I really want you guys to have the opportunity to do is tell us why you were interested in this project and provide a little bit more background about your health center that we might not have gotten through the application or the assessments. Things like, whether you have special populations or special interesting programs, anything that's colorful that can help us learn a little bit more about your health center. Then we'll go into a review of the clinical needs assessment, then after by Stefan, and then we'll move into the performance improvement assessment. Now, during each of these sections, I know everybody's busy. If any of your staff have to leave, please let us know, and so that, for clinical, maybe the people that are responsible for performance improvement aren't able to be there, but we'll probably spend about an hour on each of those sections just to give you a better sense of how long things might take. Then after that, we want to come together and have a discussion about kind of our reactions to what happened on both both sections, both of the assessment reviews, and really get a chance to start prioritizing where we're going to move with your health center. So throughout the entire day, those that are able to stay, I'd just like you to start thinking about some of the themes that you're hearing, and we'll discuss those at the end. And then as we close, we're going to discuss next steps. But as a housekeeping question, can I ask if any of you have to step out at any point just so we can have an idea? And let me unmute you. Give me 1 second. And you're unmuted now.
Okay. Hi, this is Jenny. I'm the pharmacy director, and I think the clinical representative for the team. I actually have to leave at 11 to go to another meeting. I'm sorry, I didn't realize it was going to be 3 hours. So maybe we can get done before that. We'll just proceed quickly.
Yeah, and the clinical is scheduled first, so that should probably be okay.
Okay.
All right. And also, if we need breaks, it's a long time. Please let me know. Perhaps we can break between clinical and performance improvement, or before we start the discussions. But I'll check with each of you before we move on to each section.
Okay, thanks.
All right, so then that brings us to, oops, I'm missing a slide. I just wanted to give you a chance to tell us a little bit more about your health center and why you're interested in this project. So you have the floor, and I'm actually going to mute us so we can reduce background noise. And for anybody muted, if you do want to ask a question, we also have a chat feature within WebEx, so feel free to use that as well.
Okay, this is Janice, and I'll give you a little bit of a brief history of our health center and some of the populations that we serve. We actually grew out of a grassroots movement. I was a neighborhood nurse, which was a concept of placing a nurse in a low-income community to do referral and outreach to this community. After a short period of time, we realized that there really was no access to health care. So as a grassroots movement, several churches in the neighborhood and neighborhood association leaders, we came together and formed an organization in October 2002. In October 2003, or July 2003, we started our health center with $5,000 and a loan for our doctor's salary. The overwhelming need had people lining up within the first week. We predominantly are in an African-American community with very high STD rates, very high incarceration rates, with very little access to primary health care. So we have seen significant growth. We've grown from 3 employees in 2003 to over 103 employees now. In 2007, we were requested by a small free clinic that served the migrant seasonal farm workers about an hour south of us to also consider serving that population, and we received migrant funding in September of 2007. So we actually have 2 sites which we consider both high risk for sexually transmitted diseases and infectious diseases, which would be mostly our population in Lima is very poor. It's a cultural mix. We have probably about 40% African American, 60% white, non-Latino in Lima, and then our population at our migrant site is 90% Latino or Hispanic population, with high mobility within both populations. We kind of have a model care that's a little bit different. We believe like the one-stop shop. So we try to be primary care. Whatever you need, we should be able to do 98% of your primary care within our facility. So we offer medical, dental, we do pediatrics, we do counseling, which is part of an integrated services, very much team concept. We have a dispensing 340B pharmacy with many programs that help increase access to medications. We have a very robust clinical pharmacy program. We actually have 4 clinical pharmacists who do a lot of our chronic disease management for our more difficult or challenging patients in disease pathways, including we started hepatitis C about 2 years ago. Mostly those patients came to us from screening from the plasma center. Young adults would go in and find out they had hepatitis C when they were turned away from donating plasma. Many of them are uninsured, and we have multiple patients that we're handling here because we could not get specialists to take them. So we've developed a pretty robust Hep C program here within our facility, which obviously is very much coincides with the risk of HIV infections. Some of our challenges with our HIV program is we have very little actual diagnosed within our community, though our population is high risk. We've not had a Ryan White funded program, and our community is it's a community of about 100,000 in our county, but about 40,000 in the city of Lima. People know each other's business, so typically our HIV positive people, though they are here in our community, they tend to sneak out of town for their treatment, so it's not known within the community. One of the opportunities I think that we have here is the potential for people to be, we served about 60,000 visits last year. So I think a potential for us to really make an impact is the fact that many, many people come here for many, many different reasons, and that there offers some security in you can come here for whatever, and people don't know that you're coming here for HIV care or for whatever kind of care, because everyone gets their care here. And that's been some of the challenges when we've had an infectious disease doctor locally do HIV, then people were afraid to be seen there, and then it gets out in the community that they were seen, and then no one wants to go back for treatment. So we're hoping that that's a little bit of the dynamics that we can offer here that will be an advantage to the patients in our community that need that. We started universal HIV screening in all departments, including dental.
September of 2011.
In September 2011, and we just recently signed an agreement that we would be primary care provider for any HIV positive people from our AIDS Resource Center. Our community's not been served well because we are kind of in between Dayton, Ohio and Toledo, Ohio, which have much larger populations. So typically any kind of funding that would be specific for HIV have come to Dayton and Toledo, and we are either the last county to the north or the last county to the south for all of those providers. So we're kind of an afterthought on many services. So we're really hoping that we'll be able to offer better care to the people in our community so they can stay local without having to worry about their confidentiality being breached. Excuse me. Right now we do medical, dental, behavioral health at all of our sites. We have pharmacy at our Lima site. We're hoping to have pharmacy up by July in our other site. And the other exciting potential for us is we have a new access grant pending for a rural county about 30 miles here, which we've scored very high, so we expect funding on that by the end of March, which is a very different community. It's rural, it's white, but there's a very high incident of substance abuse and IV drug use in that community. So we think that there's probably people who need this type of care also there in that community too. So that's kind of a little bit about us. Anybody want to add anything? We tend to be, we very much are based on the team concept of care. We are very heavily dominated by family nurse practitioners and clinical pharmacists. We have 2 physicians, another full-time physician will be joining us in May, but we have 4 pharmacists on staff. We have 2, 4, 6, 8, like 10 or 11 mid-levels. We have a very extensive dental program. We have 4 licensed independent social workers. So we're not the typical health center, which has more physicians and less other healthcare professionals. We tend to have our teams be a little bit different, and that's why the makeup on our team for this collaborative is different than I would imagine what you typically see. So quite honestly, our physicians, though our medical director, very key to our QI, tends not to drive new program development. New program development tends to come from our clinical pharmacy department.
Thank you for that. I think that was very helpful for all that are on the line, just to get a little bit more, a better sense of the reason why you wanted to participate, as well as a little bit more information about the patient population and the communities that you serve. I've unmuted all of the lines right now. Does anybody have any questions before we move on? Okay. Well,
I don't have a question. I just have a comment. This is Mazdak. I just wanted to say that I'm hearing a little bit more about how your organization started, and from the grassroots, and how much you all support the idea of team-based care. Just really, you guys are the type of center that we love to work with. So just really excited to move forward with this project with you all. Thanks for sharing.
Absolutely. Thank you, Mazdak. I think we agree on this end as well. I know I did have a question in terms of when you were describing your community. I believe you mentioned that you had about 40% African American in your community. Is that correct?
Yeah, in Lima, that's the percentage we serve in the health center. It's about 20% across the county, but the city of Lima is very poor. We're very low on median incomes. And the population of African American in the city is about 40%, and 80% of our patients at the Lima site come from the city of Lima.
Okay.
And Kim is our data girl, so she's going to correct me when I'm wrong.
And the reason why go ahead.
Oh, no, that's fine. Go ahead.
No, I mean one of the reasons why I paused at that because part of this project is funded through the Minority AIDS Initiative, so we do pay attention to the racial and ethnic makeup of your patient population. So I think we noticed that we might want to just double check what you submitted in your application in terms of the percentage of race and ethnicity of your patient profile. But thank you. We'll just double check later on.
Am I muted, or can you hear me?
I can hear you.
Okay. Our migrant site, New Carlisle site, I think we're about 90%, aren't we? And then,
yeah, on our application, it looks like overall, because we did all our patients together, it kind of looks a little bit skewed because with both sites and with one site being mainly Hispanic and migrant population, it makes it look like our percentage of Black and African American is 28% overall. But we see a lot of patients that are Lima site, and those tend to be a higher percentage of them are Black African American, whereas in our smaller site, there's a higher percentage of Hispanic. On the application, it says 13% of our overall patient population is Hispanic, but at that site, it's closer to 80% or more.
Wow. Okay. All right, thank you.
Yeah, it's combined data from two sites, yeah.
I see. Okay, well, if there are no other questions or comments, we should move on to the clinical question. And I'm going to, and Kimmy and Mazdak, I'm going to mute you so that we can reduce some of the background noise, okay? All right.
All righty. Good morning, everybody, again. I was wondering if I could start by just asking a couple of follow-up questions about some of the clinical pieces that you spoke about that seemed really interesting. Would somebody mind describing a little bit how your hepatitis C program works, and in particular, sort of what roles your mid-levels and your pharmacists play in that program?
Yeah. Sure. This is Jenny. I'm the pharmacy director. Our hepatitis C program, like Janice said, started a few years ago out of necessity. Remember, the majority of our population is uninsured, and so the local GI docs would not accept our patients for treatment for hepatitis C because they were unable to afford, the services. So,
right.
With that being said, we saw a need, which is typically how we drive our programs, is see a need that our patients, are missing. So that drove us to learn more about the hepatitis C program. We brought in speakers and some really good specialists from the Toledo area with some help from Roche at the time, sponsored a program to get us started. We rely on the patient assistance programs that are available to get our patients that are uninsured their medication. And so it just seemed logical that the clinical pharmacy team would have, a big piece in the treatment and follow-up of these patients. So what happens now is a patient is identified as a hepatitis C positive patient, and we have actually a clinical protocol that we put in place for the organization so that the providers understand what needs to be done to make a patient qualify for treatment, because as we know, not everybody qualifies for treatment. So there's a checklist of things that happen prior to them getting enrolled in our quote-unquote hepatitis C program. And how Janice described our work and our team environment is the clinical pharmacist, behavioral health, and provider literally work in the same hallway. They're in the same rooms with the patient. So when a patient is identified, behavioral health and clinical pharmacy is brought in immediately, and we discuss treatment options, check if they have any specialists that they may see for mental health issues. We bring them in on those decisions also. Do a lot of background work before we actually have a patient receive treatment. So there's a lot of background work, as you know. And then once treatment commences, we pretty much become their best friend for the course of treatment. Clinical pharmacy follows them very, very closely. The patient actually is scheduled with the clinical pharmacy group to come in on a weekly basis at first, and then they come in on a monthly basis. We have a calendar set up which describes all of the lab work and everything that they need. Behavioral health is pulled in for evaluation at every single visit, along with the provider comes in at every visit. So we do an integrated care visit for these patients, and then a lot of follow-up and contact both in the dispensing pharmacy when they pick up their medication, and also via the phone, just to check in on them, make sure that they're getting the lab work that they need, and make sure that we can stay in touch with them. With our population being so transient, it is a big issue, being able to stay in touch with the patient so we can continue their care. We also have a high instance of substance abuse, and so we do drug screens on these patients throughout their treatment, and we have some guidelines that we follow in case, we do come back with positive drug tests. So we screen patients very, very, very closely, I guess would be the term, in the beginning, to try not to get patients, started on the treatment if we don't feel that they can finish it, because we all know that really once they start it, they do finish it. So that's been our biggest challenge, is really identifying patients that are going to be able to complete the therapy. And we have had many that have completed, and most of them have sustained viral response, so, have achieved SVR. I do have to admit, though, it is a problem follow-up with patients, a year after, because of the transient issue. It's difficult, but we do our best, and we've had success with those patients that we've been able to get through the program.
Great, thank you. I think any success with hepatitis C is a success. So that's fantastic. And if I could just have a follow-up question before we dive into the assessment, can you tell me a little bit about how your pharmacists function? It seems like pharmacy is a huge part of the care team, which I think is great. And I know that pharmacists oftentimes function differently depending on what setting they're practicing in. Could you tell me a little bit about how your pharmacists function in terms of actually providing patient care or consulting on patient care?
Sure. We do a couple different things. We have a dispensing pharmacy, which we're a 340B retail pharmacy, fully functioning, just like you go into any other pharmacy. We just dispense 340B medications to our patients only. But we do also have about 8 other programs that we run through our dispensing pharmacy. So our pharmacists actually rotate, and they do a clinical pharmacy program, which means they have visits one-on-one with patients. They do integrated care visits, and they do provider education programs, but they also work in the dispensing pharmacy. So they really rotate through both, practice settings, let's say. Now, we do run an ambulatory care center, so what's interesting is the clinical pharmacists work hand in hand and as a team member with the providers and the behavioral health specialists. So
Okay.
they do see patients one-on-one, but many times it's an integrated visit where you have the provider, the pharmacist, and the behavioral health provider all in the room dealing with the same patient. So we actually aren't restricted to just one model. We use multiple things to be able to meet the needs of the patient. Does that help clear things up? Okay.
Yeah, no, that's great.
We're very involved in the HRSA Collaborative Patient Safety and Clinical Pharmacy Program and have been involved in that for the past 4 years. And so we've been able to develop a pretty robust clinical pharmacy team over the course of those 4 years. And so, you know, we're pretty used to developing new programs and trying to integrate it with the rest of the team. Not to say there's not struggles, but, you know.
Right. And does anybody have any thoughts about how, or thought about how you might, I know you said for hepatitis C you use the patient assistant programs, but is there any thought about how, and I'm not familiar with ADAP in Ohio, I know that it's had some trouble, as many other state ADAP programs have had, but it sounds like you guys have a robust dispensing pharmacy, so have you guys thought about how antiretrovirals might be managed in that setting?
Yeah, it's definitely one of our concerns. I mean, you know, as we go forward with this program and we are managing medications for patients, you know, once we reach that level, we definitely would set up a program very similar to our hepatitis C program where we would have, you know, patient adherence program and be much more closely in contact with the patients. And there are some ADAP programs that are available, but we don't really have much information on them. You know, the 340B program offers a discount for patients for medications, but still the antiretrovirals are so expensive that most patients would not be able to afford that. But definitely the patient assistance programs would come into play here.
And one of the philosophies of our health center is we're not a free clinic, and everyone is expected to pay their fair share. We slide our fees very low. We're probably one of the lowest health centers in the state of Ohio. Minimal visit for a medical visit is $10. Minimal for dental is $20. Behavioral health is $5. So we do slide our visits very low, and we don't turn people over to collections and all that stuff. But one of our policies is we do not dispense meds below the acquisition cost, plus a small dispensing fee. So we do not give free meds. The only few are on the few patient assistance programs, but we restrict those with some rules around them. So that is one of the challenges, and it really fits to our philosophy is if you have a chronic disease and if you have high blood pressure and I give you free medicine in January, what are you going to do in February? I mean, our goal really is to get people on a regimen that they can sustain themselves within their budget, within consistent, you know, guidelines. So that's one of the challenges is how we're going to access those kind of services for people.
Awesome.
Great. With the patient collaborative that we're in through HRSA, the Patient Safety Collaborative, HIV is actually a cohort that many of the teams do follow. So I do plan on reaching out to them, you know, and pick their brains on how they get their patients access to medication. So I feel like we have a network of people across the country that we can learn from too.
Great. Thank you very much. So we're gonna, if anyone else has any, if no one else has any questions, we're gonna move on to your HIV primary care learning community assessment tool. And first, just let me say thank you very much for taking the time to fill this out. I think everybody did a really great job. It's very complete from our clinical team standpoint here. The first thing that I'd like to talk about is looking at your care team and the list of providers that you've put on here. There's definitely quite a few, which I think is fantastic. And I just wanted to sort of ask you what your thoughts were around if you were planning on including all of these providers in the training program. I see you have some pediatric NPs on here, quite a few LPNs, MAs, which we do have a curriculum for. So are you planning on involving all of these providers that you've listed here?
Yes, we are.
Okay. Okay, great. And do you have a sense among the providers, and I'm not sure if you've spoken with them about this project or program yet, about their willingness to sort of participate in a lot of this intensive training? Are there any on your team who are maybe champions, besides you all, of course?
Well, we have spoken with them about the program and expansion. Basically, like we said, started in September of 2011 of doing the HIV screening. And then we've explained to them that our goal is to increase what services we're able to offer. That was just the beginning phase, if you will, of how we were going to be offering HIV services to our patient population. And so they're aware that the changes are coming. They don't know the details or the depth because we weren't exactly sure either where the program was going to go from here. As far as a champion is concerned, I think we probably, our medical director or clinical director, Dr. Morris, has been the most active in terms of conversation and dialogue about where we're going, and is very much in that role of being the champion and encouraging all of his other team members.
Mm-hmm. Excellent.
We run a little bit different here.
Mm-hmm.
We typically don't give providers options on what they choose to do and not do as part of our clinical practice. I mean, we very much say, you know, these are the challenges our patients have, and these are what we're going to work on and we're going to develop in. So we take providers, some who are very gung-ho about things, some who are lagging back, but the expectation is that everyone provide a level of service to all of our patients. Now, and we do that by developing QI indicators that cross over some of the things that they're not thrilled about doing, and eventually it becomes part of their practice. And I think we understand that there are people at different levels of comfort, but for us as an organization, we can't have some patients getting really great care who are working with Dr. Arredondo, and patients of somebody else not getting care at all. So we standardize what we do, and then we roll it out, and it's a little bit like electronic health records. Some are excited about it in the beginning, some don't want to do it, but guess what? Everyone's on it. And once they get on it, they can't think about doing it the other way.
And I think what we've previously mentioned numerous times is our model of care requires multi-disciplines to be participating in the treatment planning. So it's really never just a primary care provider who is leading the cause, if you will. It is the entire team that has different responsibilities for that or to that patient. So when we identified who our providers would be and who would be a part of that care team, there is a multidisciplinary approach that will be used, and so everybody will really need to be the champion at those different levels.
And what we've found is often our LISWs, our behavioral health counselors, and our pharmacy take the lead, and our medical teams kind of come along, if that makes sense.
Yeah.
We're changing their world more than they want to change, but
it's definitely not the medical model that you would find in most health centers or even in a hospital type setting.
Right, right. And I would like to just verify really quickly that you reported that you probably have about 2 patients who have HIV who are being treated at your center. Is that correct?
That's correct. That was on our 2011 UDS report.
Okay.
We're not actually doing treatment for them for HIV.
They're just on your census
just for
there?
The primary care, correct.
Okay. Okay, great.
And when did our agreement with the AIDS group?
That started in January, yeah.
So we have a new agreement that we will be the primary care provider.
Oh, okay.
For the AIDS Resource Center, so we anticipate that we will be getting more referrals.
More referrals. Okay, fantastic. And has your testing initiative, which sounds pretty robust, been able to yield any new diagnoses?
Not thus far.
Okay.
And we also do that screening in our dental program. It's not just in primary care. So we're population focused. We do not, we're not disease focused in our screening process. So any patient that is on site is flagged in our EHR. That needs an annual screening, and no matter where they're at within the organization, and that screening process occurs.
Okay, great. So we're going to move on to the HIV care capacity, and where we asked you to match your site to one of our 4 care models. I just want to confirm with you, you chose external HIV care, and we agree with that. Did you all have any questions about that?
No.
Okay, great. And then you also put yourselves at the foundational stage, which is great. And no questions about that? Okay, awesome. The next question that I wanted to ask as we go on to mentorship and clinical consultation is, do you have a relationship right now with your local AETC, your AIDS Education and Training Center? It looks like you had some training from the Ohio Department of Health.
Correct. That was when we started the HIV screening process.
Okay.
We had a representative that came in and trained a core group of individuals that would roll out the screening process with our clinical teams. And then we also had a speaker that provided education to our providers.
Okay, okay. Any trainings from the AIDS Education and Training Centers, or any relationship with them that you guys have had?
I think falls into the problem where we are usually the southernmost point, an hour and 20 minutes away from the people who get the funding. So we have had offices that have been set up, and then they're closed, and then they're set up again, and they're closed, and they have a presence in the community, and then they go away for a year, and then there's another presence for a little while, and then they go away a year. And that's been a consistency for, I'm not kidding, the last 15 years.
Gotcha.
So I tell you who is out there doing this, and I'll guarantee you no one else in the community can tell you either.
Okay, okay. And to your all's knowledge, you're not able to identify somebody who may be able to provide some mentoring or some clinical consultation services as you move through the training? It's okay if you don't.
I think there's a infectious disease doc within the community who is very interested in what we do and taking care of our population. So I'm sure that Dr. Ellis would be willing to do training for us. And I'm sure if we really reached out to the Toledo group, we probably could get some resources from that group also. It's just they're not a consistent presence in the community. So I think we probably have a few things that if we nurtured them and drew them out.
Right, right. Okay, great. Thank you very much. So I think we're going to move on to the training plan development piece of the assessment. And it looks like you said that you do have regularly scheduled provider meetings. It looks like on Thursdays in the morning. Are those weekly or monthly? So monthly it looks like?
Those are monthly. It's the first Thursday of every month.
Okay.
And that is the providers, and it's an hour and a half long meeting, and typically the last half hour of that particular meeting, we have the clinical supports team, the nurses, medical assistants join the providers. So if there's any shared information that affects them as a team collectively, then that is discussed at that time. Okay,
okay, great. And have you guys typically used this monthly meeting for training purposes as well?
Yes. It's a great opportunity because we block off their schedule so they're not concerned about trying to get back to their patients during that hour and a half. Okay.
Because I know sometimes it can be difficult when you only have one hour and a half a month with all of your providers in one room. So sometimes it can be tough to squeeze in everything that you need to squeeze in.
If we do not cover things that maybe are specific to just the medical, because when we say our providers have this hour and a half meeting, that includes our clinical pharmacy and our behavioral health providers too.
Great.
If there's something that is specific to medical in particular, the following Tuesday afternoon at lunch is another meeting that's kind of a carryover from that Thursday so that we can continue discussion and education or training.
And we regularly have lunch and learns where we'll provide lunch for providers, and someone will come in The challenge with that is if one person runs over or someone's having a bad day,
right.
the consistency of attendance at those are a little hit or miss. But we
right.
do block schedules for, you know, planned training programs.
Okay, great.
We're big eaters here. We feed everyone for every meal. That helps.
We like eating here too.
Yeah, that's awesome. That's great. Okay, fantastic. So, so then moving forward, it looks like you said so there may be a possibility for under an hour a week for group training activities at your site. Is that consistent? Do you guys feel that that's doable?
Yes.
Okay. Okay, great. And then in terms of, again, sort of with the individual provider, and I know this is kind of hard to assess, you feel like maybe it's probably about under an hour a week that they may be able to devote individually to the learning proficiencies and the training program?
We also use Essential Learning, which is an online training program. So if there is specific things that are more of a self-study kind of thing, we can put that onto our e-learning. And on occasions, our providers can take CMEs to do those programs. So if indeed there is a bulk of self-learning, we can put that on there and give them CME time to do that.
Okay. Fantastic. Okay, great.
All of our providers get 2 weeks paid CME. So if there are a conference or something specific to this program, you know, that's always an option for them to attend also.
Wow, that's fantastic. Mona and I both are, yeah, we're on our way. That's fantastic. Okay, great. I think that's it for me. Any questions?
Did you ask about the barriers, and did you talk about how to manage those barriers? I just missed that.
Yeah. Mona's asking about, you know, you listed on here the time away from direct patient care might be a little bit of a barrier from the training. Do you know how you might sort of overcome that barrier? I know you just gave some ideas about CME, and you have your online training as well.
Well, this is an example. This is the type of a meeting that we wouldn't pull a provider out of clinical care to attend, because we can gather this information, because it's really not clinical in nature, it's not really direct patient care changes. So things like this and things like that would drive some of the documentation, all of those things are things that we don't believe we need to pull a clinician for. So for us, we will save them and their time, and we kind of guard their clinical time pretty tight, because we do a lot of stuff with not a lot of money. So, so they're seeing patients when we're doing this type of work, but when needed, we will pull them in. But we, when we do that, we really try to be very efficient about it, have it very goal-directed, and not a lot of fluff. It's kind of the down and dirty, this is what you need to know, all right, get back to work.
Okay, great. Thank you.
There's just one thing that we didn't put on the assessment, and we're going to review with you at some point in this conversation the clinical next steps, what we will be doing next prior to you coming to the meeting here in April. And that just takes about two minutes. But what I was wondering is, in your mind, when would you and the team be ready to start your clinical training?
Start at what? I'm sorry.
The clinical training.
Oh, the training.
You know,
what's a realistic start date for you?
Well, I guess I would like to get a handle on exactly what is in the training and what it consists of before deciding how to roll it out. I mean, with different disciplines, we may be able to, if we have a provider out on vacation, to capitalize on that with some of the support staff and rotating them through some individualized training. I guess I would have to see the training and kind of wrap our head around it to see how we could roll it out best with our staff.
But we are not big planners. We are more jump in and get going.
Yeah.
So you know, we're not going to be a group that says 6 months from now. So
No.
once we get a handle on what type of training is needed, I mean, we will implement it within the next 2 months. I mean, we're change junkies, so we like to keep things rolling fast.
Right. Well, part of our role in this partnership is that we are able to give you quite a bit of support in that training. And I don't know how much time we have in today's phone call to really go through the elements of the training and the package, but that's one of the, every other week we'll be in touch with you about some of these things so that by the time the April meeting comes, you'll have all that information. But we do have a very structured and a very, it's modified and adapted to fit your needs, but there's quite a bit already available for you, and we're here, we support you very actively.
Now, do you see us doing a big kickoff before the April, or do you see us coming to the April meeting and coming back armed with ready to start it?
We're thinking started at, the meeting will be a very critical.
Yeah.
If you had an urgent need otherwise, perhaps we would make a different plan, but that's only about 6 weeks away now.
Yeah, it's pretty close.
So we have a lot to cover with you.
That would be the kickoff.
That would be our kickoff, and we would come back in action mode after that.
Exactly, and we hope that you would actually leave that meeting. It's our hope that everyone leaves there with their training plan in their hand.
Okay, that will work for us.
All right, great.
Okie dokie. All right, I think I'm going to turn it back over to Christine.
Okay.
Unless you all have any questions.
Nope, I think we're good.
Okay, thank you.
Christine, do we
Okay. Start.
Do we need to ask them if they would like to hear those next steps?
Would you? Yeah, and I'm sorry, Joe. I wasn't sure if it was Jenny or Jolene. I don't know which one of you had to leave. But do you want to hear some of the next steps, just so since we're good on time, just in case you have to leave and you're not able to stay until the very end?
No, I mean, I have until 11 or slightly before 11. This is Jenny. So I definitely would like to hear you talking about reviewing some of the training pieces.
It's a 4-item list of what we're going to be doing over the next weeks. I just thought if someone had to leave now, you might just want to hear that. And we'll talk about that much more.
Yeah, please go.
Oh, yeah, that's fine.
So let me just go back to the slide, and I'm just going to jump ahead to the end. But if you look at the clinical, one of the things that we'll do, we're going to have a kind of a 2-week cycle in terms of the clinical. You'll first receive, so the next step, you've completed a kind of a broader clinic level assessment, but now Mona and Stefan will distribute assessments to each of the people that you've identified on your part of your care team, and they'll have individualized self-assessments to complete. And are you giving them about 2 weeks to complete those?
Yeah, but we'll have an orientation with you, and you actually will be the ones handing them out. But we'll explain very much in depth, and you can decide if you want that for us to go through it with you and with them together as a group, or if you're comfortable and you can do it there. But that's the next step.
Mm-hmm. And then you'll have you'll come back together, and they'll discuss the results of the self-assessments from each of your care team members. And then after that, about 2 weeks after that, they'll get to what you wanted to hear more about, the HIV training package and all the elements within. So you have a better understanding of what's coming, what's available, and then you can really make a determination of when you can start. But it sounds like we've all agreed that it'll be after the April meeting. And then the training plan development will begin after that.
This is Kim. I have one question. As we're looking to 2012 and our QI goals, is the self-assessment that each of the clinical folks fill out, is that like a pre-test where it's scored and then there's a post-test after the training kind of thing?
It looks somewhat like a pretest, but that's really not the intent of it. There's no real scale. There is a scale for them to assess their own capability and their own skill level when it comes to providing HIV care when we separate it out into different proficiencies. So, for example, very quickly, the first proficiency that's available for providers in particular is managing acute retroviral syndrome or primary HIV infection. So they will have an opportunity to sort of rate themselves in their ability to provide this care independently or provide this skill independently or in consultation or what have you. It's not really meant to be a pre and post evaluation. It's more of a way for them to sort of do a self-assessment really of their own skill set, and from there we take that all together and use that to develop the training plans.
And at the end of the first year, you won't really have the full picture until we review the stages of integration, but at the end of stage 1, when your team reaches the end of stage 1, then they become more eligible. There are tracks that are available for professional certification in HIV specialists for both nursing and for prescribing clinicians. So not at the first step of training, but if you continue to go throughout the stages that we offer, in parallel to us, we are not a certifying body, but in parallel to us, you would become then eligible individually to sit for that exam, which then does give you that credential, but we are not a credentialing organization.
Okay, wonderful. Thank you.
Yeah, we can help you through those steps, though.
Okay. Does anybody have any other questions before we move on? And at this point, everybody should be unmuted.
This is Jenny. So do we expect to have, I see here every 2 weeks up on the screen, are we going to be meeting like phone calls like this every 2 weeks?
Shorter.
Yeah.
Much shorter.
Much shorter. and just with the clinical group. Yeah.
Well, I just need to we need to get it on our calendar, so I'm just looking to try to figure out how that's going to work. So how often we need to meet.
Yes, what we need to do is we have several groups that we're working with at the same time. So we couldn't right now offer you time slots, but within a day or so, we'll be able to put out a calendar and you can select times that are available with us and you can sort of book in. But right now we don't have that. This is our first call actually, so right now we don't have that available. But within a few days, we'll be able to get back to you in terms of scheduling those clinical activities. Some will be webinars, some will be just, nothing will be longer than 45 minutes.
Okay. Thank you.
All right, so we are halfway through. We're at 9:56. I just want to check to see if anybody wants to take a break before we move on.
I think we're good. We're good on our
You're good? All right, well then great. Then I will pass the baton to Mazdak and Kimmy. Mazdak and Kimmy, you are now a presenter.
Okay, can everybody see my screen? It should be on Section 2, Performance Improvement Assessment.
Yes.
Great. And I'm so excited to hear that you all are change junkies because I think we'll get along very well. I do want to say, although these sections are split out, that the teams really see performance improvement as being a road to getting the clinical change to happen. And really, what we're trying to do is figure out the best possible way for the clinical transformation to occur. So with that said, instead of going in order in all these sections, I thought I would ask you all, what do you think of each of these sections? Revenue maximization, quality improvement, which I was very happy to see what a robust program you all already have around quality improvement, cultural competency, recruitment and retention, appointment access and reporting and population management, which you all see as the key priority areas for yourselves in terms of making the clinical shifts happen. And then I figured we could start there.
You scared us. I'm not sure.
Did I? Would you rather we just go in order?
There's a lot of stuff out there. We're nodding our heads.
All of them.
The question is, what do we think we need the most work on to make this clinical change?
Exactly. Yes.
Okay. For us, what I think is the biggest key is really just focusing our attention and having some skilled guidance. We are very adaptive at bringing new programs on. So what we're really looking for, and we think we have the great structure in place. So we will be, on our end, doing many of the same steps that we did for Hep C, developing a protocol, doing education training, doing some PDSAs to make sure everyone's up. And so we feel like our biggest need is for you to give us kind of the additional help and guidance for this chronic disease, is how we see it.
Because much of, when you're looking at the four sections of the performance improvement, they all relatively go hand in hand. Our quality improvement drives what we do within our organization in every aspect of care. The access is an issue that we deal with no matter what their chronic disease might be in terms of getting the patients in the door. As Janice indicated earlier in our conversation, we saw 60,000 patient encounters last year, so we have an enormous need in our community, and the access to our HIV patient population, we have already agreed to provide that if we can get the patients through the door. We welcome them. We want them to feel like this is a place that they can come for their care, and I guess probably not knowing that they could come here was the biggest obstacle, and I think by us signing that memorandum of understanding with our local AIDS resource, that is going to open that door much more into welcoming that particular chronic disease patient population. And cultural competency is not as big of an issue for us in terms of whom we are serving. It's that training module that you are going to be providing us so we can help educate our team members to feel more comfortable and confident in directing and educating our patients the most proper way.
Okay, I mean, I think what would be helpful for me to hear is when you went through this process, and I think looked at all of these different sections for when you were taking on Hep C, for instance, what you saw as being potential areas that you would like more support on around the process. Does that make sense?
What we really need is clinical training and making our providers and our staff feel more confident in the knowledge that they have about, treating a patient in their HIV condition. Comorbidity is something that we're very used to here, and I'm sure that once we start looking, we're going to find, obviously, some more patients that, have HIV infection. But our providers are afraid, basically, right now. And that is only because they don't have the knowledge. They're very quick to learn new things and excited about new opportunities to take care of the patient, especially with a need that's going underserved like this. So, that's really it. The clinical training piece is what I see as the biggest challenge for us to get up and over.
Yeah, and that's the second. Sorry, go ahead.
And I think that's part of, the change that's happening across healthcare is as we get more defined pathways and more defined treatment plans, that care can move from specialist office to primary care. And I think that's the somewhat scary place for a lot of our advanced practice nurses because, what our goal is always push the care down to the lowest level, but it's still competent. So that's as we took on Hep C, which was typically managed by a specialist, which is where chronic HIV care is. And tell me if I'm speaking crazy, but to bring that down to the family practice and then also be able to push that down to advanced practice nurses. Because we have a huge number of unserved people still in our community. We've only been a funded health center for less than 7 years. And we continue to, we saw 3,000 visits, we saw 10,000, we went to 20,000, went to 30,000, we went to 60,000 visits last year. So our climb of the number of people, we still estimate there's about 30% in our direct community without a primary care home. So our goal is always to figure out how we can do the most care with the least amount of money. And that we found is getting the most training we can get so that we can bring those services in that probably 10 years ago nobody was managing hepatitis C patients in a primary care office, at least at FQHC, and now we're doing it with very good outcomes. So that comfort level, and that's, I think, part of the evolution of healthcare that's going on right now.
Yeah, I think you're completely sane, not crazy at all, and that is exactly what the point of this project was about. I do, so, and that clinical component, you're definitely going to be in good hands with AETC. This section that we're talking about right now are the other sections. How do we work around the performance improvement to support that, as we mentioned?
And I'll just say it right now, always figuring out how we pay for this is always a challenge. And we're a little bit different since our management team is all clinical. We typically decide what we're going to do, and then I figure out how to pay for it a little bit after the fact. So, as always, that's part of the, always the challenge of balancing it.
Okay, so does it make sense right now? I was thinking, as you all were mentioning, just around recruitment and retention issues, around actually getting HIV-positive folks, identifying them, getting them into services as being one of the places where you're at right now, and then also the revenue maximization that we'll start on those sections and then move on to the others?
Yes.
Okay. So I was curious to hear a little bit more. I know you implemented the testing recently, and it's been regular testing. That you've all faced any barriers with implementing HIV testing?
We had one staff meeting where people went, "Oh my gosh, what will we do?" And then after that, we did a lot of training, and we haven't had any. I'll let Jolene speak to it, but after the initial, oh my gosh.
The reaction, I think, was based on what Jenny spoke to earlier, and that was just a lack of education. I think the teams get a little more nervous when they feel uneducated or uninformed, so that they're not able to deliver the proper information to their patients. Once we were able to start giving them more literature, more information from our training, and exit care that is given to our patients, they relaxed a lot more in terms of, okay, if I get a patient who tests positive on the screen, I feel much more apt to lead them or guide them in the right direction following all the training that we've had. So they were less reactive to the initial surge when we said HIV screening is going to begin occurring. I think they all held their breath, not knowing what's next. That has lessened, decreased tremendously. It has become just part of the everyday workflow. Nobody has been reactive to that whatsoever. I think this next step is going to be an even better reception, because they're going to feel, again, that they're able to give more to their patients. Their initial reaction was, if I get a patient that is HIV positive, now what? Because we don't have the resources in place here to handle that. I think they're going to feel much more apt to knowing that we are beginning that process of being able to provide these services to your patients.
Great. And have you all done any marketing proactively around letting folks know that you're doing HIV testing, or targeting groups that might be specifically at risk in your community?
Quite honestly, we have done no marketing because every day we are so packed with patients that if we start marketing, we're not sure we can handle the influx of patients.
We're still at about 350 new patients to our health center a month.
Yeah, I was also reading about your issue with not no-show rate, I'm sorry, third next available appointment with,
Yes.
Yeah. Okay, that makes sense.
We're hoping to be funded for a new access point in the county to the east of us, and we're seeing probably several thousand patients from that community. So we're hoping when that site opens up, that will take some people from this site in Lima, and we'll be able to open up a little bit of room here within the community. We also have an application for capital for another site within Lima, but that's 2 years out. But we have always struggled with capacity.
I think that signing with the agreement with the AIDS Resource Center is the biggest step that we have taken to inform the community that we're here and available to provide services to the HIV community.
Yeah, it was good to read that. I'm wondering how does that work? So you're saying that they're referring folks to you specifically for primary care, not necessarily for treatment of their HIV disease. Is that correct?
You know, in all honesty, one of the reasons that this actually came about is this particular center contacted us with patients that are already HIV positive needing dental care, and they had no access within the local community to getting that. So that's what initially opened the door, and then as we started more dialogue about the services that we offer here, they were very interested in partnering, if you will, with us to give these types of resources to their patients that were already positive.
Okay. So in addition to all the clinical support that you all want to get, does this feel like a priority for you all around getting more support around recruitment of new HIV-positive patients, separate from the testing initiatives that have already been done? And then the separate piece from that, once folks are linked to care, retaining them within care, does that feel like something that's a priority for?
What we're really committed to is developing patient-centered medical home that really fits the needs of all of our patients. And so and our ultimate goal is to serve our community and serve them well. So if there are patients in our community, our goal is always to get people into care who aren't in care and then keep them in care. I mean, our goal is that we take care of you from when you're a baby till when you die, hopefully as a very old person. So it's not that we're specifically have a new mission that we want to go out and reach out to this community in particular. It is we want to reach out to everyone in our community, and this is obviously a group in our community that haven't had the services that they need.
That makes sense. Okay, I think what I'm gonna do then is just go back to revenue maximization, and then we'll answer the questions for the rest of these sections. And if these things feel like priorities that you're not getting supported in other ways, let us know. Otherwise, it does seem like really the clinical stuff is where the concentration for you all would be. So you did talk about revenue maximization or figuring out how you're going to pay for these services as being a big issue. So right now you were saying that 42% of your clients are uninsured. Can you talk to me a little bit more about how you all get reimbursed?
Well, you know, we're a 330 funded project. So we actually, I've got the numbers because we've just done some QI on it. We do about $4 million worth of care to our uninsured patients. Their slide is about $2.9 million. We get about $2 million worth of grant dollars. We have programs, including our pharmacy program that is revenue generation. So, you know, we are always very close with the dollar because we invested into, quite honestly, our clinical programs. So for us, we try very hard to get anyone who qualifies for Medicaid or any other services qualified, but that's always a struggle. Our migrant site is currently about 67% uninsured in medical and 92% uninsured in dental. So that is an extreme challenge. We work hard at keeping our costs low. Our per visit costs are lower than the average across the state and nation, and plus we also are very productive as our workforce is. So that's kind of where our challenge is. We always try to find revenue sources for new programs. So obviously this is going to take more resources than, you know, doing immunizations that we've been doing for many years. So we will obviously always be looking for grant dollars that can support us in this effort. And that would be great if that was a potential, if you had your eyes and ears on things, grants that might be coming along that would help us have a little extra money to be able to do this, that would be great. But that's kind of, we always figure out our 330 grant dollars are our meat and potatoes. But we like gravy and dessert, so we always get supplemental grants.
You all do like food as much as we do.
We have no foundations. We get no hospital support, other than we get hospital support for one dentist in Lima. We are very much an independent little choo-choo train that says we can. So that's what we work very hard on, is trying to come up with the extra that we need to make some of these programs worthwhile.
Okay,
that we can actually fund them.
Great. So definitely, I think collectively we'll keep our eyes out for any potential funding opportunities. You also mentioned that you had done QI around revenue maximization. Can you talk a little bit more about that? Did I mishear that?
You mean about our income revenue?
Yes, yes.
One of our projects that we're looking at next year is our self-pay collections. We only collect about 50% of what patients owe us. We don't believe in turning anyone over to collections or any of that stuff, but we do believe everyone should pay their fair share. And quite honestly, the organization has gotten a little lax. People don't feel like they have to pay. So we're adding a QI project of self-pay collections. And what we're proposing is that we're going to do a certain match goes to the health center. Above a certain amount will go a third or a fourth to an employee pool as a bonus. And then the rest would go to the health center for any self-pay collections above the 50% mark. So that's some of the efforts we're doing on revenue management. The other thing is we're looking at some denied claims data, so we're looking at that. We had uninsured children as one of our goals in the past, but our uninsured children are very low except for our migrant farm worker population that are very fearful of immigration issues. So that population, we don't think we can get it below the 20%, which it is. So those are some of the financial kind of guidelines, in addition to us hustling everywhere we go.
Yeah. Well, those QI initiatives are the type of things that we're hoping to support other centers with. Is that? It sounds like you guys are already well on your way. Is that something that you all would like support with?
You know, we would love to hear any information about best practices on self-pay collections, and we would love to have some national benchmarks on what people are actually doing. You know, it's hard for us to know whether we're doing well compared to other people or not doing well, or some people are collecting 85% of what they do, but they have barriers. We don't want to create barriers to care. We want to create a culture of people paying their fair share. So it's how we strike a balance that we're struggling with.
And especially, I mean, you all have a very specific population that you're working with, too, so I'd imagine you would want the best practices from folks that work with similar populations.
Yes. Yes. Yes.
Yeah. Okay, can definitely work with you all on that if that ends up being one of the priorities. Anything else in terms of, sorry, go ahead.
I have a question.
Yes.
Do you have any resources or know of any possibilities, I don't know, I'm just kind of brainstorming here, about some infectious disease residency programs that will be looking for, you know, kind of off-site sites, you know, like if their main site might be doing infectious disease residency at a hospital or with, you know, a specialty program, and they would want to serve a population similar to ours, maybe we could get in on a once-a-week infectious disease resident that would come here and work with us.
I think that's a great idea. I personally don't have information on that. I can look it up, but I'm wondering if folks from AETC know more.
Yeah, we're can you hear us?
Yes.
Yes.
Okay. Yes. We will really be able to work very closely with you on that as part of the training plan.
Okay.
So if you can identify opportunities, and then we'll be identifying opportunities, I don't see any reason why we couldn't try and get you on grand rounds or something like that. Is that?
So are you talking about having an opportunity for an ID resident or a fellow to come to your clinic to do HIV care?
Well, what I'm doing is just, I'm brainstorming. We actually have dental residents that come here, and we have pharmacy residents. We actually run our own pharmacy residency program here. I'm just thinking, you know, maybe we could reach out to our local infectious disease specialist, and if he gets ID residents that rotate through his site, maybe they would come down here once a week just to, you know, kind of get a handle on what's going on with our population. It's a fresh mind. It's somebody that can maybe do a little bit of training to our other providers. I don't know. I'm just trying to think of other resources that we can tap that will be free.
we have a pretty good process for working with you on that, and with the ATCs locally. So I would say think about it and get some possibilities in your mind, but it probably would be better until you have a look at what the training package is and what we're really talking about. And then we have built into that training plan a place where that type of local resources, either your people going out occasionally or people coming in, we have a place to build that into the training plan. So if you can identify people, that would be possible, but I don't know if you'd want to actually go ahead and make firm arrangements until we talk about the package and the approach.
Yeah, no, not right now. We're thinking just, later on, down the road.
Absolutely.
Okay, good. Okay.
Okay, we're going to go back on mute.
I like the way you all think, though. Very nice. So are there any other questions around the revenue pieces, or should we move on to quality improvement?
I think we can move on.
Okay, and quality improvement, I've seen in your application that you all are accredited for PCMH through AAHC. It also says that you all are currently pursuing PCMH recognition. Is that another recognition?
Yeah, ours, the medical home designation that we have now is through AAHC, which is the Ambulatory Care Accreditation. When you talk about the patient-centered medical home, most people are recognizing the NCQA standard, which has a lot to do with meaningful use and e-prescribing and a lot of that stuff. So we are, hopefully, going to apply by summer for that. We're getting our last piece of e-prescribing up. So that's kind of, we're hoping to apply in the. Of course, we told them only a level 3 will be acceptable. So,
why shoot for anything less?
That's the other thing that we're working on.
Yeah. Okay. And that's a lot of the work that we've done with health centers in the past, and that we were hoping to do through this quality improvement piece was to plant the seeds for becoming a patient-centered medical home. So I'm wondering, with the quality improvement piece or any of the other pieces with patient-centered medical home that you think would be applicable to this project, if there's anything you all are struggling with or feel like you'd need some extra support around.
Yeah, I think our biggest problems are getting our e-prescribing up, and then the other piece, which is really, it's a burden of money, getting the patient portal and getting some of that electronic communications, which I think would be really probably great advantage to many of the patients that this project may serve. But quite honestly, the patient portal is $40,000 we don't have. But I do think it would be really great to be able to implement some of those new technologies and keeping connected to some of these patients that might fit this project. Texting, Facebooking, some of those things. I'm 51. I don't do any of it. But I hear it's great stuff.
Yeah, those young kids today.
But quite honestly, that's just more of a function of dollars. We know what we want to do. We just don't have the money to do it.
Okay, and I mean, I think that there might be the opportunity, maybe not with the patient portal necessarily, but where e-prescribing or electronic communication overlaps with some of the clinical work with HIV patients. We can talk about ways of potentially supporting you around that. I did also, if you go back strictly to quality improvement processes, PDSAs, I quickly was able to read through the minutes for your QI meetings, and it sounds like you all have your stuff together around that. I'm wondering if you can talk a little bit more about your quality improvement process and if there's any support around that you feel you need.
Our quality improvement team, I think I'm not sure if I sent our team members, but it consists of people from multiple areas and multiple disciplines throughout the health center, from front desk and billing folks and finance to clinical folks, and administrative team members are definitely very active in our QI team. We meet quarterly, but the meetings are much longer. They're about 2 hours, 2.5 hour long meetings. As you can see by the minutes I sent you, the minutes get pretty detailed, and that's just a synopsis of all the reports that are actually attached to it. We try to pick out QI measures and indicators every year that focus on different areas of the health center, from patient satisfaction, employee satisfaction, the clinical goals, operational and integrated care, and then we're also now doing specific medical home recognition goals that are needed for our AAA-HC accreditation. A lot of those have to do with access to care, continuity of care, provider-patient relationship goals as well. So it's pretty robust and in multiple different areas. I'm trying to figure out what else. We use the Plan, Do, Study, Act model to test things. We actually started a new one this morning on patient education in the room with screensavers. So we do that quite a bit, and anybody is able to do that throughout the health center, not just people in the QI team, and they are provided education on that through our e-learning. I'm trying to think what else.
Kim's a QI rock star.
Oh, wow.
It sounds like it, and I really, what I like hearing about what you're talking about is that it really seems like you all have developed a culture of learning throughout the whole team. It's not just you, Kim, but it sounds like everybody's involved in recommending PDSAs or implementing them, which I think is rare and wonderful.
We like PDSAs, so.
I usually hear the opposite. So yeah, change junkies, unite. So I mean, I think for the QI piece, then what might make sense as we move forward is as you all work with the developing clinical QI measures around HIV, that will work closely to figure out procedurally or process-wise if there's any way that we can support it. But it sounds like you guys really have a really, like I said, robust process. So
for 2012, we've kind of brainstormed, and we're going to use our work that we're doing in the HIV Learning Community Collaborative that we're doing now for this year of 2012. And that's why I'd asked the question earlier about the pre- and post-test to kind of evaluate how much we've learned and change in our assessment. So I think for this year, that's what we're going to use, and then next year I think is when we'll really look at a clinical indicator related to HIV.
I see. Okay. Well, whatever you all end up settling on, I think specifically in relation to this project, we can help bolster the process however you need us to. Yeah. But like I said, I think anything we would give you, you probably already have. But we'll keep talking about that. In terms of cultural competency, you all mentioned that in general, you all feel pretty good about your health center's management of difference with population, but specific to HIV and AIDS, I guess the webinar addressing working with LGBT populations seems like something that would be helpful for your team.
I do believe that that would be helpful. Yeah. I mean, we do race very well. We do lots of poverty stuff. But I think that the gay, lesbian community, I think there is still stereotypes, and I think that would be a good addition. So that may be another QI indicator that we do, is we do something on cultural competencies. So.
Can you talk a little bit more about the work that you have done in those other areas around race and?
You know what? It really is always kind of come from where we grew from. We grew from a very cultural competent. I mean, it was a neighborhood-based program. I mean, my board was called a bunch of amateurs. They'll never survive. They're a bunch of they don't know nothing about healthcare, and both hospitals had pools to when we were going to close. So we came from a very, I mean, my board started, I was probably 80% African-American on my board of directors. And many of my boards of directors who have been here for 8 years. So we kind of grew from that. Our hiring practice is we try to be very sensitive to that. We want our health centers to match the demographics of the people we serve. So we have probably one of the most diverse work teams. Our migrant site has probably 70%, I don't know what it is, Hispanic is in Spanish is their native language. So we try to just be that, and then if you just are that, then you don't have to have a lot of training on it, because you just are. So that's kind of our philosophy. So I see that, with, HIV always comes to stereotypes of homosexuality and all that kind of drug use and all that stuff. So I think that will be another area which we can really focus a little bit on some of our cultural training for this next year.
Okay.
That make sense?
It makes sense to me.
Okay.
Do you, in terms of the patient surveys, what sort of what survey are you using?
We're using a survey through the Midwest Clinicians Network at this time, but we are transitioning into using for the, in order to get NCQA medical home recognition, they give you a couple of bonus points if you use their patient experience survey, which I do believe is just coming out. So we will probably be transitioning to that one. But I did hear Midwest Clinicians was updating theirs to become accepted as a patient experience survey. Okay. And so I need to look at the latest version now, but do you happen to know if there are any questions specifically around a patient experiencing that their provider are culturally sensitive? Jolene just stepped out, and she may know that answer better than me. I want to say yes, but I'm not 100% positive.
Yeah, I can look that up pretty quickly. I believe that it does.
On patient surveys, do you know if they ask the question about the provider being culturally sensitive to them?
Midwest Clinicians.
No, it is not on there specifically in that capacity. It's more about time and if they felt that the provider listened or heard what their needs were, but it does not specifically ask about the cultural sensitivity.
Okay. Have you all, is that something?
Many patients probably don't know what that means.
That's right.
I mean, most patients don't know what that means.
Yeah, I think you'd have to ask that question differently, yeah. Is that something that you all would be interested in gathering information on?
I think that would be helpful, yes, and I think our providers would appreciate whether the patients feel that they are sensitive or not.
Okay, so that's an area that we can work on. Anything else on cultural competency?
Nope.
We discussed recruitment and retention. And then we have appointment access. Again, this looks like an area that you all spent a good amount of time working on, at least around third next available appointment, and it sounds like you all have some real external barriers to reducing that, at least until you open up another site. Is this, we have worked really closely with a bunch of health centers to work on some of the measures that lead up to third next available appointment. Is this an area that you all feel like you've exhausted and come up against that wall around space, or is this something that you'd want to continue to work on before you open up the space?
Our physical space definitely has created limitations that unless you guys have deep pockets that you're willing to help us expand.
I'll write you a check tomorrow.
Our new Carlisle site is completely open access, and they can be seen within on same day or next day. It's mostly our alignment facility that is really struggling.
How long has New Carlisle been at open access?
Since July 1st, I think, of 2011.
And how has that been?
They've only been in their current site for just a year.
Well, 2 years in September. It was a small farm worker site out in the country that we just did a new downtown location, renovated a facility. So we increased the capacity there significantly, and it'll be 2 years in September. So we've continued to add providers there. So we figured it's easy to add open access when, you've got more capacity than patients at that time. The challenge down there is we're seen as the Mexican clinic, and the people in the community who are, you know, non-Hispanic don't view us as the place for them to go. So since we've been in this new location, that's transitioning. So it was a very easy way for us to do open access and then just maintain that.
Yeah, it seems like a great population to do it with, too. Okay, and so we can continue to work on that if you all feel like that's an issue, or if there's anything at the Lima location, the Lima location, that you feel, we can look deeper into that. I don't think this call would be necessarily the time to do that. Any questions or follow-up around appointment access?
Nope.
Okay, and for reporting and population management as well, you all seem to have answered yes to most of the questions here. So I'll just ask, in terms of when you hopefully have this large HIV positive people living with HIV and AIDS that you're serving, do you all see any barriers towards generating reports, creating registries, or developing clinical actions from these registries with this population that might be different from other populations?
No. We have electronic health records, as you saw, and we've learned how to pull some reports from it. So.
Yeah. You all are easy. Say that again?
Both of our sites are on the same program, and when we get funded next month in Canton, it will go live on the same program. So we really kind of simplify, and we'll be able to pull reports specifically to each site or to population, whatever clinical indicators.
The biggest hurdle is just making sure our providers diagnose and use the proper coding so that we can pull that data for the most part. But we have started to control that a little bit more with our template development, which Jenny is our guru for, and making sure the proper coding is attached to those templates for diagnosing and documenting. So we have tried to alleviate as many of those barriers as possible in getting the incorrect information.
That's good, to make it foolproof. I think that's great.
Yes. And also, our electronic health record is used by all providers in all disciplines. Our dentists use the same one that our nurse practitioners and our physicians use, and our behavioral health LISWs use the same one as well.
If only everyone could be like you all. Make
Make
life a lot easier.
Yeah, but not everyone likes us this much.
Really? I do. So I just wanted to recap. It sounds like the areas where we possibly could work together the most is around the revenue maximization, particularly figuring out ways to support you around the QI towards making sure that you all get paid, especially from the uninsured populations, and that you're collecting money through the billing. So that's one area. The other area was around the cultural competency, specifically though around the populations most impacted by HIV in your particular communities. And then we were saying maybe a little bit of stuff around access, but did I mention recruitment and retention yet? That was the big one. Recruitment and retention.
We talked about that.
Yeah. So recruitment and retention, specifically looking at once you all feel ready, the providers feel more comfortable seeing more folks living with HIV, how to maybe get to a place where you're actively recruiting folks that might be at risk for HIV, and then once you have those, being able to retain them into care. I have another question, and if folks called and said they felt like they were at risk for HIV and wanted an appointment, is there a way to fast track those appointments, or what would be the process for? Would they wait 22 days if they were?
in terms of needing to be seen by a primary care provider specific to HIV, or just needing primary care?
Needing to be tested. Saying, we know you do provide HIV tests. I feel like I am at risk. I want to get tested. What would be the process to get them tested?
If they are a new patient, then we would connect them with one of our providers and establish care with them and get them a new patient appointment.
Okay. And how long generally would that take? It sounds like it would depend on what clinic.
It can vary. It can take up to those 20 days, but it also, if we have cancellations, we try very diligently to contact those patients and say we have an opening and get them in a lot sooner. So
Okay.
It can vary from week to week, just depending on our flow.
Gotcha. Okay. That's something that maybe we can explore further too. But so do those 3 areas that I mentioned feel like, out of all these areas that we covered, the ones that make the sense to prioritize in terms of our work together?
Yes. And I would think the revenue, I mean, quite honestly, I have very little understanding on, what services are out there. Is there any special programs, their Medicaid eligibility differences? All of those things would be really helpful for us.
Okay. I think for everybody that's part of this program, yeah. So.
Yeah.
Great. Thank you. That's the end of my set of questions. Do you have any questions for me around the performance improvement portion?
Nope, not at this time.
As I said, it was a joy. Thank you.
Thank you.
I'm going to turn it back over to Christine.
All right. Let's go to discussion. So, well, thank you for being so patient and being on the phone. Now, do you have any reactions, any comments about what we've discussed in both of the sections today? Mastic was able to help to kind of prioritize some of the areas that you would touch on in the performance improvement area.
No, I think we're excited to get started.
Mm-hmm. Yeah.
Oh, great. Okay. Do you see anybody from our staff? Do you see any themes or anything you want to follow up on? We were on mute on our end. No? Okay. Well then, in terms of next steps, we covered some of the clinical ones earlier, but just to back up a little bit, we will start assigning your organization staff contacts so that you know specifically who you need to work with, and you're not reaching out to everybody just to try to get to one person. So we'll assign a coordinator to each of your organization. That person will just be responsible for making sure things are going, that your needs are met. Then you'll also have a clinical coach from our staff, and you'll also receive a performance improvement coach that will also be working with you. That coach will be from PCDC. So we discussed some of the things that are coming up in terms of clinical side. So every 2 weeks, again, you'll have some sort of activity. Do you have any questions about that? We went through it.
I just have a question on the. I assume that since we have a clinical coach and a performance improvement coach, those will be different meetings. Is that right? Because what I'm looking at is I would probably split my team. That all 4 of us wouldn't be on all calls. That maybe
No.
So I would probably participate in the performance improvement, and I know Jenny would be clinical, and Jolene would be clinical, and Kim probably would be performance improvement with me. So that we're kind of maximizing our time also.
Okay. No,
Does that
absolutely.
make sense?
Yeah. No,
Okay.
that's what we actually expect. So the primary clinical contact is that Jenny?
Yeah, that's fine.
Okay. All right. Thank you.
And the performance improvement key would be Kim. See, I talked faster than she did. Put me down. I put her down.
I put Jolene in that packet as the performance improvement leader, though. So,
but we're going to move her to clinical with Jenny, and we'll put Kim with me.
Yeah. I guess I didn't understand the whole process, so and looking at the key things, it's probably is more me, but I'll bring in Jolene when I need to.
Okay. Wait, which me was that? I'm sorry. I'm trying to learn your voices.
Oh, Kim.
Okay.
So at this
All right.
point, Jenny and Jolene will be on the clinical, working mostly with the clinical, and Kim and I will be working mostly, this is Janice and Kim, will be on the performance improvement. And then we will all pull together on whatever meetings you all believe we all need to be there, and then we will kind of bounce. We tend to just pull each other in on meetings whenever we need to kind of regroup here.
Okay. So then, again, in the next 2 weeks, we'll start working with you on the self-assessments. We're probably going to try to identify a time that is going to work for the majority of the health centers in the community to do a call or a webinar, just so we're discussing how to complete the self-assessments with you, Jolene and Jenny. We'll be working with the clinical learning leaders to do this, and then we'll have you guys distribute them to your staff. And again, since we ran through the clinical a little bit earlier, I don't want to go through it again, but Bazak, did you just want to run through what's to be expected on the performance improvement side?
Sure. I think similarly to the clinical side, Kim and Janice, within the next 2 weeks, based on the discussion we had today, we're going to draft some prioritized performance improvement objectives and have a discussion with you if those make sense for our work together through the end of the year. And then based on that, we'll develop a prioritized project plan, kind of an action plan for meeting those objectives in those areas that we discussed. And then right now we have set we're going to figure out a time to meet. We found that the best practice is around performance improvements, that the work, at least initially, be done weekly check-ins, so not very long calls, but just to make sure that we're all on the same page. As we continue to work together, we may see that that's not necessary till the end of the year, but we will work with you once we've identified your coach to identify a time that works for everybody.
Okay, perfect.
And then we look forward to meeting you face-to-face during the April 19th to 20th meeting.
Okay, great fun.
And we're still working with our meeting planners. We will have, we're crossing our fingers that we'll be able to have logistics out to you by tomorrow, actually.
Oh, great. Are you going to give us some pointers on how to enjoy the nightlife of the city?
We sure can. I mean, I think we did that for the first year, the first learning community, so we can let you know just as long as you're back in time for the meeting. That's all. It's a beautiful time of year to be in D.C.
That's right. We work hard and we play hard, both.
That's great. All right. Well, thank you, everybody. That's it on our end. Do you have any questions?
Nope, I think we're good.
Great.
Okay, great. Well, I think I speak for everybody from the ATC and PCDC that we really, really look forward to working with you guys throughout this year.
Good, we are too.
All right, and if you have any questions in the meantime, you can reach out to me, and I believe you have my contact information, Christine@healthhiv.org. Okay,
yes,
great.
I do.
All right, well, if we don't hear from you before the weekend, have a wonderful weekend.
All right, have a great day.
Thank you, everybody.
All right, bye-bye. And Mazdak, I'll call you afterwards.
Okay, just give me 5 minutes.
Okay, that's fine.
Bye.
Bye-bye.
Bye.